Hello everybody. Over the next few minutes we will talk about using whole body MRI for the assessment of patients with metastatic bone disease, talking about the MET-RADS system. Here are my disclosures. So what is MET-RADS? If you look at the official publication, MET-RADS is Metastasis Reporting and Data System. I like to say Metastasis Response Assessment and Diagnostic System because it more faithfully reflects what the system is. Why do we need it? To overcome the limitations of conventional imaging when assessing patients with bone disease. So what's wrong with what we do currently? Current imaging tools such as bone scans and CT scans lead to poor confidence in assigning the clinical states of patients and assessing therapy benefits if they have bone disease. So for example, we are unable to accurately predict the presence and extent of metastatic disease, and the late detection and the volume underestimation can misguide the therapeutic approach. Let me show you an example. Here's a 55-year-old man with a low PSA, has a 3 Tesla MRI scan, shows locally advanced prostate cancer, and high-risk prostate cancer was diagnosed by an in-bore biopsy, so all high-precision diagnosis. As a staging procedure, the bone scan is recommended in the guidelines, and the bone scan shows 2 lesions, shown here in the red arrows. These were evaluated by a CT scan. The CT scan is normal at both sites. Question: does he have bone disease? Is this oligometastatic disease, in other words, less than 3 deposits? Should he have pelvic radiotherapy, which would be indicated for locally advanced prostate cancer with oligometastatic disease? Should these 2 lesions be treated with metastasis-directed therapies? I don't think you can answer these questions using these 2 sets of images. So he had a PSMA PET-CT and a whole-body MRI scan as recommended by the local radiologist, and you can see this metastatic deposit is positive on the PSMA PET and it's positive on the whole body MRI, and if you look at the spinning MIP image you can see he's got polymetastatic disease, not oligometastatic disease. Similarly, if you look at the rib, again it's positive on the PSMA PET and on the whole body MRI. So we've completely changed the outlook for this particular patient. Another problem with current imaging tools is we're not able to identify early patients who are not benefiting from a new treatment. This means that we impede the progress of patients to alternative therapies, and this increases costs, increases toxicities without providing benefit. Here's an example. So, 57-year-old female receiving Herceptin, pertuzumab and Zometa following induction docetaxel. This was on a clinical trial. So a whole body MRI on the left and on the right, but CT scans in between, which showed stable disease on RECIST criteria, which are part of the clinical trial. If you look at the spinal MR imaging, this patient is clearly progressing. This patient is clearly progressing, and you can see that on the diffusion sequences also. So there are 3 major problems with using CT scans for assessing bone disease response. 1, RECIST criteria don't work. Bone disease is considered non-measurable. Number 2, progression occurs and you don't even see it, which means there are lost opportunities for timely interventions. Number 3, sclerotic progression and sclerotic response are really difficult to distinguish on a CT scan. And that's because the CT scan indicates the matrix response to the presence of tumor cells, not the tumor cells themselves. So with this background, the MET-RADS standard was introduced with a number of aims. The first aim was to establish the minimal technical parameters for whole body MRI data acquisition which would be suitable for quantitative analysis. The MET-RADS standard defines 2 protocols, the core protocol and the comprehensive protocol. Now the core protocol consists of a sagittal T1 and stir sequence, axial or coronal, T1 Dixon techniques, 2B value diffusion imaging. That's it. Half an hour, you're done, and it's used for detection and characterization, and this is the protocol that we usually use for multiple myeloma for disease detection. Here's a typical core protocol. Sagittal T1, stir, coronal in this particular instance, Dixon technique. Look, the whole body, 57 seconds. Diffusion sequences, 4 stations, reconstructed here as a coronal MPR and as a MIP sequence. The comprehensive sequence is slightly different. Yes, we continue to do the sagittal T1 and T2 sequences, but you can see that the T1 Dixon technique is done in the axial and coronal planes. This is another B value that's done. A T2 sequence is also done axially for registration purposes, and you may or may not do regional evaluations of the brain, and I'll talk to you about that in a few seconds. So here's a very typical patient with prostate cancer getting a comprehensive protocol. So stir, T1, coronal, fat fractions from a Dixon technique, T2, axials from a Dixon. Here are the diffusion rate imaging. Here is the B800 MIP sequence. And you'll notice there were 2 abnormalities here and here. So for this, we just use the native images, and for here, we use dedicated sequences to zoom down. So for example, if you look at the dorsal spinal lesion, this is an area of fat, poor bone marrow, and you can see by zooming down here and here, we can see internal iliac lymph nodes in this patient with non-metastatic castration-resistant prostate cancer. We almost always do other sequences. So we do a UTE sequence, usually in the coronal plane, but more so nowadays in the axial plane to look at the lungs, and it's very effective for that. We also almost always do a brain flare sequence, and this enables us to look at the osteonecrosis of the jaw, and we may see metastasis, in which case we would give contrast. All in all, we would say that the whole comprehensive sequence should take less than 1 hour. Okay, so here is the comprehensive and the core protocol, just compared so that you can see the differences between the two. Now, another aim is to develop objective criteria to assess the response of bone disease. Objective criteria to assess the response of bone disease. And of course those don't exist at the moment, and they're called the MET-RADS criteria. And then we want to summarize in every region of the body what is the likelihood of response on a Likert scale. So a Likert scale is a 5-scale system where 1 and 2 represent response, 4 and 5 represent progression, and 3 is stable. So if you take the response assessment category for progression, so there are 2 progression categories, progression likely and progression highly likely. And if you look under bones, what we've said is an unequivocal increase in the number and size of lesions, an evolution of a focal lesion into a diffuse neoplastic process. So everything you might expect from the images on the top left. You'll notice there's no diffusion criteria. The only diffusion criteria is that the lesions that you see must be in an ADC value that's in the active range. So more than 650, usually less than 1200 or 1300. So between 650 and about 1300 is where most tumors would be. So here is a patient with primary resistance to androgen deprivation therapy. You can see this patient's clearly progressing. You can see it on the T1, on the stir, and on the whole body diffusion sequences. Now, let's just segment out the bone marrow, and you can see the volume increases from 70 to 600 cc's, progression. But look at the ADC. The ADC does not increase appreciably. So you can see here that the mean ADC increases from 840 to 930. So not much of a change. Okay, so just an increase in volume, but not much of a change in ADC. On the other hand, if you're looking at response, not only do you have morphological criteria, but you also have ADC criteria. And the ADC criteria were introduced because as you cell kill, so the water moves more within a tissue. So if you look at response highly likely, category 1, okay, so a return of normal marrow in previously areas that were infiltrated by either diffuse or a focal infiltration. All of us would agree with that. But look at the ADC criteria. You'll notice a 40% increase ADC from baseline, yes, or an ADC that went from less than 1400 to more than 1400. Both morphological and diffusion criteria for response assessment category highly likely. Okay, so here's the typical patient who's responding to treatment. This patient has retroperitoneal lymph nodes, extensive metastatic bone disease. Here's the T1 and stir. Here's the T1 and T2s. Now, look what happens to the T1. You see the T1 seems to get worse. The T2s are about the same. Maybe the spinal cord is more clearly seen on this particular occasion. But look at the diffusion sequence. The diffusion sequence, clearly you see the signal intensity drop. And here's the ADC map. So here is the examination number 1. You can see a low ADC value. 705 is the mean. Look what happens after treatment. You can see that the ADC value increases. Okay, so this is why we've incorporated a diffusion sequence and the ADC change into the response assessment category for 1 and 2. Now, we clearly want to standardize our collections so that we can report on what's happening in the body based on common anatomical patterns of disease. Okay, so common anatomical patterns of disease for prostate cancer will be local regional lymph disease, which is prostate and pelvic lymph nodes, skeletal sites, as you can see, and soft tissue disease that all of us know. So, for example, metastatic lymph nodes elsewhere, retroperitoneal lymph nodes, liver, lung, and other sites. On the other hand, we know, for example, for breast cancer, it's going to be different, right? So, local regional lymph disease will be breast and axilla. Okay, spine will be the usual sites. Soft tissue sites are different. Okay, so we know it's going to be liver, lungs, brain, and then other sites. Okay, so you can see how we have adjusted the common anatomical patterns based on what we already know about disease and how it behaves. So for each site, the first thing you need to decide is the disease there or not? And if there is, you have to assign 2 response assessment categories. The primary response assessment category and the secondary response assessment category. The primary response assessment category from 1 to 5 refers to the predominant response in that region. So when you look at that area, what is the main response that you see? And the secondary response assessment category is the highest non-dominant response. So the highest non-dominant response. So in other words, if less than 50% of lesions show a mixed response, but some lesions are progressing, although other lesions are getting better, it's the progression that gets the highest score. And this is just like for the Gleason scoring system. And so here, for example, is a typical MET-RADS report. So here are the images that you've already seen. Here is the text form, and here is the MET-RADS form filled in. So, for example, if you looked at this patient, you can see the patient is progressing. So let's say lumbosacral spine. Is there disease? Yes. Right? You can see that. What is the primary response assessment category? Progression. Highly likely. That's in more than 50% of the lesions. But what about the other lesions in that? Also 50, so 5-5. Whereas if you look at the axilla here, for example, is there disease? Yes. What is the dominant response assessment category in that area? Clearly it's progression, because you can see this lymph node here has grown. What about the other lymph nodes? Well, they've stayed stable. So, is there disease? Yes. The primary response assessment category is 5. The rest are stable. and you can say this is in the axilla. You can write in here your observations, bladder and rectal involvement, and here you can assess, you can write down what you thought about different regions in terms of nodes, viscera, bones, and the primary tumor. And here's the same patient that I showed you previously, right? This patient we knew got better. For example, we said that the T1 and the stir sequences didn't change, or you look even slightly worse. So we said, yes, it was involved because there were still signal changes, but the diffusion sequences clearly showed response. So it went to primary response assessment category 1, and the secondary response assessment category is also 1. And here we've written down excellent response at all known disease sites. Now, one of the aims of the MET-RADS system was to somehow codify and record the presence of discordant responses. And because discordant responses are important. So here, for example, is a patient receiving abiraterone for metastatic castration-resistant prostate cancer. You can see that the PSA has gone down, but if you look at the disease before and after, you clearly can see discordant responses. So this is predominantly nodal disease, and you can see it here. On abiraterone, you can see the patient's progressed in the groins, but has responded in retroperitoneal lymph nodes. Interesting. So discordance within the nodes, but you also notice that there are now new bone metastases. So you can see that the disease has shifted from being nodal to bones and nodes on the second occasion. Well, how do you codify that? Well, you can codify that because you can write it down over here. So for example, if you look over here, other nodes, so groin lymph nodes would be other nodes, is it involved? Yes. What is the response assessment category? 5. These are progressing. Are there any lymph nodes here that are not progressing? No, they're all progressing. 5, 0. Okay, and here we can write major discordance compared to PSA. New disease in bones, responding nodes in the pelvis and retroperitoneum, but not in the left groin. Okay, so you get the idea about how you can start to record discordant responses. And so what are the next steps? Clearly we need to do more work in this area, and I just wanted to show you some examples of the progress that we've made recently. So looking at the primary and secondary response assessment category, this paper is now in press in Cancer Imaging. They looked at 31 patients with advanced prostate cancer. You had one radiologist with 8 years of experience, the other radiologist you can see with 6 months of experience. But if you look at the primary response assessment category, looking at bones or soft tissues, you can see that the intra-observed variability is very high, substantial to excellent. Of course, for the secondary response assessment category, the resident's not going to do as well. And that's what you notice as well, right? So you can see that the resident does not quite as well. And that's not really surprising, but that's exactly what you would expect. Now, the MET-RADS system also codifies a number of lesions, which I didn't really talk about, but you can see that that correlates with cancer-specific survival also, which is good to see. And this study is now going to be published shortly in Radiology, which was a prospective study comparing whole body MRI with CT scans and bone scans, standard of care in 43 women in a prospective study looking at women with breast cancer with bone-only disease. They had 12 weekly CT scans, bone scans, MRI scans, clinics, and blood tests. And what we were looking for is the point at which we would say the patient is definitely getting worse, you need to change treatment. Okay, now, what you notice is that 2/3 of the women progressed only on the whole body MRI scan when the CT scan was stable. 1/3 of women had progression both on the CT scan and on the whole body MRI scan. There was not one patient that progressed on a CT scan that the MRI did not see. Not one patient. And in fact, when patients were progressing in the bones on CT or the whole body MRI, if you repeated the bone scan, you can see 50% of the times the bone scan was prospectively called stable. Interesting. Now, one of the things that we worry about is this phenomenon called the Will Rogers phenomenon. We are reclassifying patients using next generation technologies. So let's say you have a population where people have no disease, microscopic disease and macroscopic disease. You know that by using conventional imaging you would get worse survival for people with metastatic disease and better survival for people with non-detected disease. Okay. Now, what happens if you use next generation imaging? Well, if you use next generation imaging, some of these patients with microscopic metastatic disease will become metastatic. Okay. So these people will have fewer metastatic disease, so they will survive better, you see. These people here will also survive better. Why? Because in here now, not only do you have polymetastatic disease, but you've got microscopic metastatic disease as well. So, in fact, both groups survive better. Right? This is called the Will Rogers effect. So the next generation imaging will increase the prevalence of metastatic disease because you have moved these two people into this group. But, interestingly, it improves the outcome for all subgroups. Now, it's interesting that you will not improve the overall survival for everybody because it's treatments, not imaging tests, that saves lives. I mean, this just makes sense. So, to improve survival, you have to combine next generation imaging with stage-appropriate therapies. Then you get an overall improvement in survival. And that's the important thing to remember. So here are my take-home points. MET-RADS provides the minimum standards for doing whole-body MRI that incorporates diffusion imaging for acquisition, interpretation, reporting, follow-up for metastatic disease aimed at prostate, breast cancer. Okay. It is suitable for guiding patient care in practice, but validation is preliminary and more research is needed on how to use it. And I would encourage you to do this. So if you want to look further into this, you can look at the original publication, or you can look at the article in the Radiological Clinics of North America that provides further guidance, and the reporting templates are also available. You can of course look at my YouTube channel and listen to this lecture again. Thank you very much.